Okay, so shall we start? Hello, everyone, and welcome to this webinar on COVID-19 and rehabilitation organized by the EFIC Covid Task Force. My name is Angela, and I work at the European Pain Federation and as an advocacy and projects assistant. Mary O'Keefe, our research projects advisor and also member of the COVID-19 task force, will not be able to join us today, unfortunately, due to technical problems. So I will be chairing the webinar instead. My colleague Melinda, EFIC's communications officer, is also here today, and she will be in charge of the Q&A session at the end. Our first speaker, Derek, is a professor of neurological rehabilitation at Oxford Brookes University in the UK. He is a doctor who has been interested in rehabilitation since 1980 and is still very interested. Although he retired from the UK NHS work in 2016, he is still active clinically and academically. He edits clinical rehabilitation tweets, runs a website, and writes articles about rehabilitation, as well as research articles. In this presentation, he will provide his perspective on rehabilitation for COVID-19. Our second speaker, Femke, is from the Netherlands. She is a physiotherapist, health scientist, and works as a policy advisor for the Royal Dutch Society of Physiotherapy. During the outbreak of the COVID-19 pandemic, she developed a position statement on physiotherapy in patients with COVID-19. Today, she will be sharing the most important information about physiotherapy rehabilitation. After both presentations, we will have time for a Q&A session, so feel free to send your questions to the Q&A section as you listen to the presentations. So without further ado, over to you, Derek.
Thank you very much. I feel slightly cheeky in that I don't actually see many patients with COVID other than my grandson. So this is largely done on what I've read and knowing about rehabilitation, and it's taken from the point of view of rehabilitation rather than the COVID side of it, which I've read about. So what I want to talk about is the problems that one sees after COVID, but then to move on to talk about the process of rehabilitation and what it is, and then how services are organized so that we can deliver rehabilitation to people with COVID. I'll be largely referring to the UK design of services, but this will probably apply throughout. And the main messages really that I want to give is that COVID has very few unique features that differentiate it from a rehabilitation point of view from anything else. It obviously arrived suddenly. It's only been here less than 2 years, and obviously a very large number of people are affected. But the problems seen are not particularly unique to COVID. COVID has stressed many systems that are failing, certainly in this country, housing, social services, and the rest of it, not just health. Rehabilitation is, or should be, holistic, covering everything within the biopsychosocial model, which I will cover briefly. It is team-based, it is done by a team, it isn't uniprofessional, and in principle, at least, a single person, single therapist or doctor or whatever cannot do rehabilitation on his or her own. And it's long-term relative to acute medical care, so it needs to work across all boundaries geographically, over time, and different organizations. And if you're going to deliver a service like that, then the service needs to be able to cope with covering different locations over time and different organizations. So coming on to COVID, I'm sure it's no different in any other country. There will be people who've had COVID will be seen in many different healthcare settings. So they'll be obviously seen in intensive care in the beginning and acute wards. They will return for hospital follow-up, sometimes under chest physicians, sometimes under general physicians, maybe neurologists. They will turn up in very many places, and they'll be seen by different specialties and different professions. Some of these people will have persistent disabilities. We still don't really know the numbers, either how many people will have it at all, or what sort of disabilities and problems they will have. But I think it is already clear that the persistent disabilities bear a weak but not very strong relationship to the severity of the initial illness. So if you can be very ill initially, but still be okay, or you can be not very ill and have a lot of problems. Somehow the slide moved on. Common problems recorded in most studies are fatigue and exhaustion, both of which are often fluctuant without any obvious pattern. Anxiety, emotional distress, mood swings, and other emotional problems, and respiratory problems, unsurprisingly, things like breathlessness. But many other system-specific problems or disorders arise. So some people, for example, will have a stroke and then have the problems from stroke, or neuropathies, or myopathies, or cardiac problem, or musculoskeletal problems. So it's a very wide range of problems can occur, both across the whole population and within an individual. So somebody might have respiratory problems and a bit of a problem with stroke and some cardiac problems and maybe some joint problems. These slides will be available to you afterwards, so you don't have to try and take in the whole of this slide, but it's really to illustrate the biopsychosocial model of illness. And I expect that the majority of people listening will be aware of it, but just to run it through very quickly, in the top left-hand corner, you have problems within the organs within the body, otherwise known as disease. Top right-hand corner, you have problems at the level of the whole body or the whole person, the symptoms and signs experienced or the impairments of function implied. Below that, bottom right, there's problems in the physical context, which is your activities. It's how you behave, what you do within your physical context. It's really essentially behavior. And then at the bottom left is the social context, is a sense who you are within your own society. Participation is the jargon used certainly within rehabilitation. And then in the middle, there's the personal context, which is the one that we forget. And that is what the individual patient or person brings to the illness. So it's their own beliefs and the label they think they have, which may not be the label that external professionals give them. They make choices, they don't want to do things, or they do want to do things which are against what anybody else is suggesting. Quality of life on the far left is in the end what the patient and we are working towards. In order to do that, the processes involved in rehabilitation are fairly standard for any problem-solving process. So you collect data, which within rehabilitation is usually referred to as assessment. Within medicine, it's referred to as diagnosis. And you identify in rehabilitation the disabilities, the activities that are limited. And then you try to work out, well, what's underlying that? What are the underlying impairments or symptoms that the person has? And then most importantly of all, you look at all the other contributory factors from all those other domains. So family attitudes, personal attitudes, the flat you live in, your financial state, everything. Having done that, you will formulate the situation. In other words, you will try and work out what is going on in this individual. So this person is presenting with memory problems, not because of COVID, but because they drink far too much alcohol every day, for example. And you'll be looking for modifiable factors, things that you can do something about, and you'll be looking to try and identify what the patient's priorities are and what their goals are, and not what you think your goals are. I don't know why this is moving on, sorry about that. Having done that, you will then act, you will do something, so you'll plan and organize and deliver treatments, and then you will monitor that to see, has it had any effect? Is the person getting worse, getting better? And then adjust what you're doing, set some new goals and work out where you're going until you finish. So that's the process, and that's no different to rehabilitation for COVID than for anything else. The interventions are all tailored to the individual patient's needs. So it will be tailored to things like the disease, the prognosis, what impairments they have, their activities, losses, and so on. and it has to take into account their values and beliefs and their own life goals, but also where they live, the community they live in, their work colleagues, their friends, their family. All of these things need to be taken into account, and each individual patient with COVID will have a different set, so you have to tailor it. I apologize for the slides moving on. I don't understand. So when thinking about rehabilitation, we need to think, well, what are the things that work? And this is an extract from a study that I published about 2 years ago about what is within rehabilitation. And the things that work in all conditions are exercise. And by exercise, I mean something that will actually make you breathless and feel that your muscles are doing work. It's slightly different from practice. So practicing some activities is clearly also involving exercise. So if I'm practicing walking, and I'm doing exercise, but I'm also practicing walking. And if I want to get better at writing, then I will practice writing. And if somebody, after whatever their condition is having problems dressing or cooking or whatever, they will practice those activities. The third part of any successful rehabilitation is education about the disorder and self-management. And the education is going to be difficult to begin with for COVID because we don't know a lot about its natural history. So that side of things, what to expect, is quite difficult. But education about what will work and how you manage yourself will be no different from any other condition. And then psychosocial interventions, which are rather poorly defined, but it really means helping somebody with their anxiety, their depression, their mood, their distress, and also at least thinking about how we can increase their social integration and their social network. And then the really key part of all rehabilitation is the fact you have tailored actions. And these specific interventions, again, are very patient dependent. So some people will need some bits of equipment, and some houses will need adapting, and some people will need orthoses. It's unlikely any prostheses will be needed after COVID, but if they had a vascular problem and had an amputation, then that will be needed. Their personal context is probably the most important, so altering their beliefs, explaining that the breathlessness is actually a reflection of anxiety, not of lung disease. Altering their expectations, upgrading them or downgrading them depending where they lie, and helping them to adapt their goals. And then looking at how they can engage themselves socially. So if they no longer can run marathons, explaining that it might be quite interesting to go for walks or for doing other things that allow them to exercise and exercise their choice, if not in the same way. And then a lot of interventions relating to impairments, pain, being an obvious example, but also focused therapy on trying to improve some particular thing, or if somebody's got a squint or needs glasses, then making sure that they have those. Rehabilitation works across all boundaries, and this diagram sort of illustrates that. So on the disease, rehabilitation will be involved acutely, dealing with symptoms, dealing with disability, and then dealing with their social networks. In terms of time, it's there from the beginning to the long term, when most people should self-manage. In terms of illness, the beginning, you're a patient and you're sick. But what we hope to do is to lead the person on to being healthy. That doesn't mean to say the same as before, but to think of themselves as being a healthy person who happens to have a spinal cord injury, rather than to being sick with that spinal cord injury. Rehabilitation is delivered everywhere from a nursing home, from a hospital, through nursing homes and residential care in the community to home. And the organisations involved will be social services, health services, employment, education services, housing, and so on. So it really does cover a whole lot of boundaries, and it has to be able to work within that. So the service that they have needs to remain with them wherever they are. The big problem is that often it doesn't. Certainly in this country, it doesn't. So when they move from the hospital to the community, it's a completely new group of people who know nothing about them, have no idea what's happened. It's got to be available over the whole time needed. So if you've got a service that's only limited to 4 weeks, that's not much use if your problem lasts for 20 weeks. The service should be able to manage from its own resources at least 80% of the problems faced by the population of people they see, and it shouldn't be subdivided in any way by organizations or other agencies. The reality, certainly in Britain, is like this. This is a district, in other words, a population, let's say 250,000, 500,000 people. And each one of these boxes represents a different service, which has different organization funding it, different rules about how you get in, different rules about how you get out, different rules about what you can and cannot access. And you can see it's a nightmare. So if you have somebody with COVID or any other condition you like, they're going to have to use about 6 or 8 of those boxes. And each of those boxes has a completely different set of rules, its own priorities, and it's not working together. And that is a huge, huge problem. Bad for patients, it's bad for efficiency and effectiveness. And what I'm suggesting is that we need, certainly in the UK and I guess in other parts of Europe, to work towards having a much more holistic healthcare service provider model. So within the same service provider, you have people who focus on the disease, acute hospitals and the like, people who focus on the emotions and the beliefs and those sort of problems, psychologists, liaison psychiatry, people focused on activities, rehabilitation service, and then perhaps less so with COVID, but certainly in general, people also focused on palliative care and end-of-life care. And all of these services should work together. They should work over time from the very beginning of an illness to the end, and they should work in parallel in liaison, not as separate systems. At present, you go to the acute hospital to deal with your disease, and then you move to somewhere else where you've dealt with rehabilitation, then you move somewhere else for something else. And you should link into all the other services. Getting there, I would suggest that COVID has precipitated major changes in both health services, so that telehealth for everything, much more emphasis on self-management, which is very much in rehabilitation, much better working across boundaries has arisen with less bureaucracy. But certainly in the UK, all of this is going to go back to the bad old days that we had 2 years ago. And I would hope, certainly in the UK, that people active in a locality should draw up a catalogue of all the services used by people with disability, what purpose they think they have, what their criteria are, what the limitations they put on their service, who funds them, the resources they have. Find 6 or 8 patients where harm or stress arises because of the problem of going from one service to another, wasting resources, delays, poor outcomes. And then go along to whoever organizes healthcare in your area and say, look, this is terrible. Patients are getting harmed, you're wasting money, we're wasting time. Can we not join up into a single rehabilitation service and indeed health service that treats patients properly? So my hope is that COVID, having completely destabilized most things, will allow us to reorganize in a way that stops this waste of time, and also means that next time COVID comes, or the next one, we're set up to deal with it before it arrives. So thank you very much for that, and later on I'll take questions.
Thank you very much, Derek, for your presentation. Femke, would you like to share your screen and your slides?
Of course. Yes. explain it? Yeah. Well, at first, good afternoon, everyone, or good morning, good evening in whatever time zone you are. Well, it's my pleasure to present to you today on physiotherapy in patients with COVID-19. I was introduced before, so then I I skipped that. Today, I will guide you through the following. First, I will shortly start with the global perspective of COVID-19 and shortly show some data from Europe and the Netherlands. Then I will zoom in on COVID-19 itself, like what does it do to the body, which symptoms people can have, and which complaints that can occur after acute infection. And I will explain the important role of physiotherapy in the recovery and rehabilitation of these patients. And then we'll continue with specific recommendations for physiotherapy. Well, of course, currently we all know about COVID, if we like it or not. Well, globally, the numbers of infections are still high. I show them here. As you can see, is that at the moment there are 231 million confirmed cases worldwide, and almost 5 million people died because of COVID-19. Well, in many countries, vaccination programs started, and it was data from yesterday. So around 6 million vaccine doses have been administered yet. The numbers of people being affected with COVID-19 extremely vary around the globe, as you can see here. The most confirmed cases are seen in the Americas, but Europe is next in line, which is, in this case, first and second place is not a good thing. Here you can see the numbers and the trends over the month and the year from Europe, and we can see that the largest increase was confirmed, or not confirmed, confirmed cases started in September or October last year. A quick look at the Netherlands, if you don't know where where it is. Here it is, and it's just to give you an impression. These are the data from the Netherlands. So we have 2 million people infected out of 70 million in total people living in the Netherlands. And important to note here is that only a small proportion of these people are admitted to the hospital. So the most of the people infected recover from home. To understand the symptoms of COVID and the consequences it causes in people, it is important to quickly tell you something about how the virus works. And that is that COVID is a beta coronavirus. So it consists of an RNA strand with a protein shell. And these proteins, they bind to the ACE2 receptors of the cell and thereby allow the RNA to enter the cell. And after the RNA entered the cell, then it can start to divide. And therefore the incubation period varies around 2 to 14 days with an average of 5 to 6. So after being infected, it can take a couple of days before people get symptoms. There's also still uncertainty about the duration of contagiousness. Some studies reported contagiousness in a range of 8 to 37 days with an average of 20. But another study found that 50% of the patients were still contagious after being symptom-free for 8 days. Well, as you all might know, that the most common symptoms are fever, fatigue, cough, and shortness of breath. but patients can also experience weakness, weight loss, headache, nausea, or vomiting. And in patients with COVID, the severity of illness can also vary. Roughly, it can be said that 80% of the patients shows mild to moderate symptoms. And as you can say that these patients can stay at home and recover from home. And around 50% will develop severe symptoms for what hospital admission is required. And then critical illness is seen in 5%, and these patients need to be admitted to the intensive care unit. After being infected, patients can experience various complaints and problems in their daily life and physical functioning. In patients who have been admitted to the hospital and ICU in particular, acute respiratory distress syndrome can be seen, which means acute failure and dysfunctioning in breathing. But we also see ICU-acquired weakness, which means a lots of muscle mass loss and symptoms of the post-intensive care syndrome. And in these patients, both physical, mental, and social problems can be seen, for example, depression and anxiety. Important to note here is that not only patients with severe or critical illness can have these symptoms. Also in people with moderate symptoms, sometimes you see these complaints or symptoms. And all patients can show impaired function on body systems, as Derek also highlighted, such as the cardiovascular system, the respiratory system, or the neurological system. In the end, after infection, patients can experience various complaints and problems in their daily life functioning. I want to highlight two studies from the Netherlands and Belgium to underline the persistence of symptoms. And this study included more than 2,000 patients who reported persistent symptoms, of whom only 5% had been admitted to the hospital. They assessed a total of 29 symptoms during infection and after 3 months. This study showed the patients reported a total, on average, 14 symptoms, and almost all people reported to have 5 symptoms or more, of which fatigue and shortness of breath were the most reported. During the infection and even after the infection, as you can see here, and 3 months later. Here you can see the impression of the health status they assessed. So before the infection, the majority of patients reported to have a good health status, which is the green column at the left side. But after 3 months, most people perceive their health status as moderate or even poor. And this is indicated by the orange and the red column at the right side. So this also shows the impact of COVID on patients, their own perceived health, but also their quality of life. Interesting, they in the same cohort, they followed a smaller group over time, so after 6 months after their infection, and they assessed health status, functional status, and quality of life again. In comparison to the symptoms reported during the infection, symptoms decreased from 15 to 6, but only 5% of these people reported no symptoms at all. Although after 6 months, the reported health status and quality of life did increase, but still a large proportion of patients experienced persistent symptoms. You can see that also here. The symptoms during the infection were at the left side, and at the right side you see after 3 months. So during infection, patients reported 6 to 20 symptoms, and then you have to think about like a headache, pain in the lungs, or pain in the muscles, dizziness. But after 3 months, patients most frequently reported still 1 to 10 symptoms. And you can see here, the change in 3 months, that's the left side, to 6 months. So then you see that's not quite a change, which you might expect from a period of 3 months. To be able to explain the role of physiotherapy, I will briefly show you the various, I call it, journeys of the patients in the Netherlands. As I said before, patients with mild to moderate symptoms go usually through COVID at home and recover from home. Patients with severe illness or critical illness will be admitted to the hospital, and some patients will be discharged and go home again, and others need more, let's say, intensive rehabilitation, which will be referred to multidisciplinary rehabilitation. But overall, physiotherapy plays an important role in the recovery of these patients, independently of the patient's healthcare setting. To guide the physiotherapy treatment, we developed clinical recommendations on physiotherapy, which included recommendations for physiotherapy in the acute hospital setting and recommendations on physiotherapy in patients after hospital admission or patients who were ill at home. Both documents are currently under revision, but I will share the main recommendations with you. Yeah, that's what I said. Well, hospital-based physiotherapy can be divided into recommendations for patients admitted to the ICU and patients admitted to the COVID ward. The main focus on physiotherapy on the COVID ward is respiratory support and active mobilization. The same actually counts for patients at the ICU. However, passive mobilization is sometimes required due to sedation or mechanical ventilation. At the COVID ward, respiratory support serves several purposes, like to improve vital capacity, to evacuate secretion, and to strengthen respiratory muscles. To prevent further deconditioning, active mobilization focuses on improving physical functioning, for example, by using bed mobility activities. Important here is that also after discharge, physiotherapy frequently needs to be continued in the patient's home setting. So then we continue to the physiotherapy in patients after the hospital admission or without even hospital admission. We described these in a Dutch position statement, but we also translated it into English to be able to share knowledge with other countries. You can find it via this QR code. I will also share it at the end of the presentation with a disclaimer that it's will be revised and the new version will be ready in January. Well, overall, physiotherapy plays an important role in the rehabilitation of patients who experience limitations in their daily life physical functioning. So specifically reduced functional capacity and physical activity and their daily life activities. This can be seen in various patients. So not only patients who are very ill, but also patients with mild symptoms can experience limitations in their daily life activities, as a simple example for walking the stairs. So the patients, let's see, ranges and age and their problems ranges widely. Physiotherapy focuses on improving muscle strength and balance, exercise endurance, breathing and relaxation. And based on the time after illness and experienced physical abilities, our clinical recommendations were divided into two main sections. The first 6 weeks after hospital discharge or illness at home, and the period after these 6 weeks. Initial treatment in the first 6 weeks focuses on gradually increasing daily life functioning. And after 6 weeks, treatment can focus on improving activity levels. But of course, the treatment is always based on the patient's needs and abilities. In the first 6 weeks, it is determined whether there are limitations in physical functioning, and therefore functional outcomes can be assessed, as you can see here. Important to note is that the patient's reaction on activities should always be monitored, such as shortness of breath and oxygen saturation. As we can see that it can decrease very quickly during or after physical activity. So the emphasis is on returning to activities in daily life living, and therefore the physiotherapist focuses on advice and coaching of the patient to gradually increase their physical functioning, for example, by mobilization exercises aimed at daily activity and exercise to improve strength, using functional exercises like 10 times standing up from a chair. During treatment in this phase, we recommend a maximum score of 4 out of 10 on the Borg scale for shortness of breath and fatigue, because many patients need to be slowed down because they want to do too much. And if so, they fall back in their recovery and can be exhausted for days. And again, monitor the oxygen saturation. In case the saturation level is decreasing, it is important that to stop and that the saturation level reaches its pre-activity level. Again, preferably within 2 minutes. In our position statement, check the time. In our position statement, we included some examples of exercises, including frequency, intensity, type, and time, or duration, also known as the fit factors. And here you can see an example to increase muscle strength, but more examples can be found in our position statement to guide you and to guide physiotherapists which kind of exercises can be given. After those first 6 weeks, there's always started with an evaluation of physical functioning, and hereby clinical outcome measures can be used to evaluate current or set new goals or just treatment goals. Oh, yeah. Well, the treatment plan, of course, depends on the activity levels of the patients prior to the infection, their needs, their wishes, their recovery of physical functioning in the first weeks, their requests for guidance, and their current physical abilities. Mostly patients need to be coached and supported to increase their exercise intensity, with a focus on patients' personal goals and focus on their activities and participation, for example, work situation or returning to sports. So in this phase, treatments aims at helping the patient to return to their social and community participation. And in this phase, the intensity can be improved, but we recommend to use a maximum score of 6 out of 10 on the Borg scale. Again, there's an example for this phase, but I will skip it because you can find everything in the statement. A short recap. So in the first 6 weeks, focus on gradually increasing daily life activities at a low intensity. And no joke, you probably really have to slow the patient down, because sometimes it feels like I'm going great. Let's do more exercises, but that's roughly not the best idea in the first weeks. After this 6 weeks, you can further improve activity levels and, of course, intensity, but always monitor and evaluate, because every patient is different and therefore unique in his own way. Also important to note is that physiotherapists are encouraged to work together with other physiotherapists or with other health professionals to ensure their adequate treatment. That's because patients' complaints are often multidimensional, so interprofessional collaboration is very important. For example, with the GP to monitor or evaluate progress, but also other professions such as a dietitian, since patients who have been severely ill, malnutrition is frequently seen. So combined treatment is important for the best treatment effect, as you cannot build muscle strength if muscles cannot be built within the body. Well, I almost came to the end, so I probably shared a lot. So I'll summarize the most important things. Well, yeah, we see that many patients perceive complaints after COVID-19, and these complaints can be very persistent. Also in those patients who have mild symptoms, that's also important. And the complaints can really affect daily life. So both old and young people can experience various and severe complaints. Well, also those patients were not admitted to the hospital. And physical functioning, I already said. So physiotherapy can play a key role in the recovery of these patients. Caution with intensity of activity and exercise is always needed. The gradually improving daily life activities is very important, and after 6 weeks this can be improved. We always recommend to monitor, measure, and evaluate so that you know what you do and you do what you know. As I said, the position statement is a work in progress. Of course, there is more new evidence emerging. Clinical experience is increasing. There's more knowledge about long COVID, which was not included in the position statement yet. So therefore, the physiotherapy recommendations will be revised and added with new information. In the Netherlands, it's a hot. The rehabilitation of COVID patients is like a hot topic. So many multidisciplinary guidelines are also developed. Yes, on the revision. Well, you can find the position statement here and more information about it. You can use the QR code or the website link. Important to say is that in the position statement, you can also find more information about red and yellow flags, outcome measures, which we recommend, treatment intervention examples, and also signs of physical and psychological distress. Then I really almost came to the end of this presentation, but I want to acknowledge the authors of this position statement. And then I will thank you for your attention. I will show a quick view on the references, but you can also find it later on the presentation. I will share it as a PDF with you so you can read and look it over.
Perfect. Thank you so much, both Derek and Femke, for presenting your experience and sharing this with us. We have roughly 15 minutes to answer a couple of questions. So one of the very first ones that we received is, and it's a question to both of you, I'd say, what would the ideal rehabilitation program look like if you had unlimited funds and resources? Derek, would you like to go first?
Well, I'd love to have unlimited funds and resources, but I think the risk would be that you would splash too much on some patients. So if I had that, I would start by saying whatever we develop needs to be for all people, not just for people who have problems after COVID. And we need to integrate services, and I'd spend quite a lot of time and money just getting people working together rather than the separate services, which is certainly a real problem in the UK. I think we need to be very careful that we don't over-medicalize people. We recognize there's a lot of fear and anxiety and psychological input needed. And so if I had enough money, I would increase the amount of psychology input into all rehabilitation services. I think that's pretty enough for the moment.
Yeah, I agree.
Wonderful to have you on the same page here. Another question we had specifically for physiotherapy. Is there any evidence that a physiotherapy program speeds up recovery? Someone is saying that physiotherapy is a post-infection syndrome and it takes time to recover. So the question is, will that time be shorter with physiotherapy?
As I'm aware, there's no large evidence base for that right now, specifically on COVID patients. In the Netherlands, there is a huge study going on, which we hope at the beginning of the next year the outcomes will be there, and that the physiotherapy program will be evaluated and measured or assessed, like cost effectiveness and effectiveness. But well, yeah, the experience from which we can speak now is that physiotherapy or other therapies if needed, of course, but I focus on physiotherapy, really helps these patients. And I would say it will, as you can talk about, speeding up the process, because you guide the patient through his rehabilitation process, focus on the patient's needs and also abilities. And I think, and that is what we see in clinical practice, especially with young active patients, so with the young and active ones who used to do like lots of things, work many hours, sports, etc. These people are not used to slowing down, so they are not used to complaints and symptoms, which they really can have after infection, and they have a high chance of doing too much, which in really they fall back and feel like hopeless. In that case, I think you can, as a physiotherapist, you can really guide these patients to coach what can be done and what shouldn't be done yet, to gradually increase and prevent the strong increase with the fall, like with the dip in the recovery. But that's more based on experience, what we see now of the last year, than real hard time evidence yet.
Thank you, Femke. Derek, would you be able to speak to this question? So
yes.
Mental health issues are more prevalent now due to also, of course, social restrictions as a result of COVID. Do you have any ideas on how this could be approached?
Well, I'm going to take the liberty of just answering the last question a little bit as well. So I think the question about does physiotherapy help needs to be unpacked and made a bit more realistic. So as Femke was saying, a lot of what the physiotherapist or indeed any other therapist is doing is advising the patient that you need to do more or you need to do less. But so there isn't a sort of recovery which you're going to improve inside somewhere. You're going to help that person to be acting at their most efficient level for themselves. So the physiotherapy might be about advice about doing more or doing less, or about what to do, or about the degree of exercise, but it isn't a single thing. It's a physiotherapist who is doing it, not a physio. It's not a physiotherapy input. And the patient will improve if you give them good advice, which may well come from an occupational therapist or a doctor or anybody else. So I just think you need to unpack that question rather than thinking it's a particular therapy in a very general sense.
Thank you, Derek.
Turning to the mental health problem, I don't think there is an answer to that, because to a certain extent, everybody gets anxious, and it's going to be a population-based system, whatever we have, because we can't possibly have a whole lot of mental health people seeing a whole lot of other people, because half of those mental health people will themselves be suffering stress from the overwork. So I think it's much more about, as they say, learning to live with it and helping people to understand what is safe and what isn't safe in terms of risk of infection or whatever it might be they're worried about.
Thank you. Another question that we had is on workplace rehabilitation. So is there any emerging guidance for workplace rehabilitation of those with long COVID?
Right. Well, my answer to that question is we need to forget the term long COVID. In this country, at least, we have something called NICE. It's an organization that sets out health policies or what gives guidance. And it's tied itself in huge knots because it won't define long COVID until 12 weeks. And then it says, well, maybe 6 weeks, or maybe some people are going to have it, so we say 4 weeks, and then they say it's 12 weeks. We should get away from the idea that we should classify and categorize people. We should say, I'm seeing this patient today, these are their problems, they've had COVID. So it's a post-COVID problem, but some of that problem may be pre-COVID, long-standing. Some of it may be related to the fact their wife died from COVID. It's not a single condition. So we shouldn't be thinking of long COVID services with the implication that there are other services for people after COVID that are not long COVID. We should be dealing it for the patient and then working out how much of that problem is due to COVID infection directly, how much of it is indirect, like post-intensive care unit syndrome, how much of it is their psychological reaction, how much of it is their pre-existing stuff, how much of it is all the social stuff, as the previous question said, social restrictions as a result of COVID. So it's not a wise idea to get hung up on this diagnostic term long COVID, because you can't define it. And you risk excluding people or treating the wrong thing. So
thank you, Derek.
My answer to that.
Femke, would you like to add anything? Or
Yeah, the only thing I want to add is that this, for me, this is why rehabilitation or treatment should always be tailored to the patient, because when you focus on the patient and the patient's complaints, but more importantly, the goals you want to achieve or the level you want to reach again, then it really doesn't matter which label you have, which is long COVID or not. It's about the complaints the patient have, and you want to help the patient and to get the patient to achieve again what he was used to. And if that takes 4 weeks or 4 months or a year, yeah, it has to be like that if that's the recovery of that patient. So I agree with Derek that we should not focus too much on the classification, but instead focus on the patient and its individual journey, let's say it like that.
thank you both. We have time for maybe 1 or 2 more questions. Let's see. I have one that is about the number of patients. So it says, after assessment and individual plan, what is the best compromise on number of patients in a physio class?
I don't have a particular recommendation about the number of patients in the physio class, because I think that depends on the facilities in where you work, and the, again, kind of the level of the patient and the amount of attention and you need to give to those to this patient. So I would say at first, for everyone, a personal approach is the most recommended at first. But if you have like many patients who are in the same phase of recovery or rehabilitation, and you have like peer support, which also can help, Yeah, I think groups are a good idea, but always, again, based on patients and not on numbers or a phase of recovery.
Derek, do you have a similar view on this?
Yes, I mean, I think we should, rules like that, rules about how many patients are a bad idea. You need to know what the problem is, what your resources are, what the patient's problems are, and you tailor it to the patient, taking into account what you can do.
Wonderful. All right. Well, I thank you both very, very much for taking the time to share experience with us and also answer some questions. For everyone in the webinar, as we mentioned, we will be including this recording on our website, and we will also include the presentations. We thank you all. Have a wonderful evening and talk very soon, hopefully. Bye-bye.
Bye-bye.
Thank you. Bye.
Thank you.
Bye-bye.